Okay, can you hear me now?
Yeah. Okay.
Okay,
You
great,
can
great, great,
start.
great, great. Okay, no problem. Thank you. Let me do it again. Uh-huh. Thank you, everybody, for inviting me to be here. I'm going to, Dr. Villegas, unfortunately, was not able to join us today. Are you able to watch? Are you seeing my screen? Are you seeing my presentation?
Yeah. Yes. Yes. You
Okay,
can
okay,
start,
okay,
please.
okay,
Welcome.
okay. Thank you, thank you. Okay, so Dr. Villegas, unfortunately, was not able to join us. She will be joining us starting in January. But today, I'm thankful for being asked to talk about the adapting clinical guidelines for the digital age. Now, this is a very important concept, and I've been listening to my colleagues making their presentations, and I think that everything that they're saying is perfect. But I take a look at it from a slightly different point of perspective when it comes to guidelines and guidelines in general. And now with the digital age, everything becoming more like Zoom and digital medicine, telehealth medicine, it makes it even more interesting, more difficult, and sometimes more easy. But clinical guidelines in themselves are a very interesting topic, and I enjoyed very much the description of my colleagues who just spoke. But let me tell you what my point of view of guidelines are from a critical care perspective. I always taught my medical students and my critical care students that as a critical care specialist, I convince my patients to allow me to cause harm and pain in an effort to help them. Uh, what that means is that, especially in critical care medicine, just like in surgery, and trauma and emergency rooms, sometimes we have to do things to the patient that causes harm to them. But at the same time, that harm is in an effort to try to help them. That harm can be surgery, can be procedures, can be intubation, can be sticking catheters in them. And all of these have certain guidelines because we have to use guidelines in an effort to try to identify when we have to do something that will hopefully give us a benefit. So again, when we use guidelines to help guide us. And I always taught this to my medical students. They are called guidelines. They're not laws. They're not written in stone. They're called guidelines. Just like in some societies, they create summary consensus statements, summary statements. So guidelines first have to be understood that they are essentially guides. They are not mandatory. And why are they not mandatory? And I'll explain why. Because this is what happens when a physician or healthcare provider sees a patient. What you see here is a patient being seen by a doctor. And these are all the steps that go into getting a treatment. So when we look at all the individual components of a physician and a patient, how the interaction that the physician has with the patient and the patient's interaction with the physician, and then also depending on the patient's background, this can be race, ethnicity, educational level, economic level. All of these things play into receiving a diagnosis, and then ultimate treatment. So when we create guidelines, we sometimes create a guideline, patient sees the doctor, patient complains about something, the doctor interprets that complaint based on guidelines or his education. And then he makes a decision, physician clinical decision making, and then patient receives treatment. But that is also influenced not just by guidelines and education of the patient, is also influenced by the patient and the patient's expectations and the patient's guideline as a patient. So what factor here is very crucial here? What the factor here is what we call clinical judgment. Clinical reasoning, clinical judgment is very important. And it is in guidelines in general, do not really address that the way it should. And sometimes guidelines can sometimes cause problems with this patient healthcare provider interaction. And what do I mean by that? And this is important because as we move more toward a digital age, it becomes even more crucial because in the digital age, we will start removing the direct person-to-person interaction. So ultimately, when we have the healthcare provider and patient interaction and all of these individual steps, all of these individual characteristics lead to a clinical decision making that leads to a treatment decision. But that also involves what we call clinical judgment. And there's always a balance between a guideline and then ultimately the healthcare provider's clinical judgment. And sometimes the healthcare provider's clinical judgment might not be 100% what the guideline says. This is important to understand because the clinical reasoning starts with the individual healthcare provider and then also how that individual healthcare provider was trained in school and in clinical practice. And these are situations that when we look at clinical guidelines, we have to understand that there will be multiple variables, including the healthcare provider's own clinical judgment. So when we look at guidelines in general, we understand that they are really meant to be guideposts or guidelines. They are developed by highly rigid scientific research analytical process. But in the end, in the real world, the ultimate guideline is the clinical judgment of the healthcare provider. Moving forward, we know also that with the corona pandemic, I know that it is here in the United States and it's being seen in other parts of the world little by little. But here in the United States, there is a big drive to taking care of patients, specifically coronavirus patients at home. So then this sets up an even more aggressive movement forward with the digital age. And what we're talking about is Zoom, telemedicine, telehealth, whichever you want to call it. Here in the United States, at least, in the last 10 years, we've been slowly moving towards digital medicine. And the guidelines have to be adapted for this because now in a situation where we have clinical medicine being based upon a healthcare provider and a patient interacting directly, and then also understanding that there's going to be a clinical thought process or clinical judgment. Now we have to integrate to our guidelines in the digital world the fact that there will be a lot of healthcare encounters through a digital medium. And in the coronavirus pandemic, besides all the devastation that it has created with illness and death and putting healthcare systems in severe stress, the coronavirus has accelerated the need for telecommunications and digital health. So before coronavirus pandemic, I was thinking that we need that in 3 to 5 years, we will be more into digital health. But the coronavirus said no, now. For example, right now here in the United States, we are seeing more and more people having to readapt their capacity to manage patients with digital health and taking care of the patients at home. But then this creates a need for new guidelines because now we have to develop an understanding of how can we treat these patients at home? When should we determine whether they should be treated in the office, in the clinic, or in the emergency room, or in the hospital? So it sets up a major problem. For example, we in the United States have known that 2 out of 3 people refuse to go to see their doctors or in their offices or in the emergency room because of the fear of contracting coronavirus. So almost 60% of people are refusing to go see the doctors now or healthcare providers. Almost 74% of people in the United States are very interested in telehealth. And they are very interested in telehealth, and it makes it for many reasons, and if they can still see their physicians. So this, again, sets up a need to rapidly develop new guidelines for the digital health. And more importantly, in the United States at least, 93% of health plan or health insurance executives agree that that facility health risks associated with coronavirus pandemic encourage payers to move more towards the home care. This is very important because 10 years ago, if you were to ask health insurance in the United States or health executives in the United States, they will not pay for home visits. They will not even pay for a telephone call to the patients. Now, over 90% are agreeing that this is what's going to happen. And why is this slide very important? Because since we're talking about clinical guidelines and moving into the digital health, we have to understand that first, the stakeholders have to want it. The stakeholders have to believe in it. And more importantly, the stakeholders must demand it. And this is the slide that tells you that. The patients want it. The patients want it, and the health insurance wants it. So this sets up a big movement quickly, and we have to address it quickly. Now, when we talk about guidelines in the digital health, we understand that in general now, we're moving towards a healthcare system here in the United States, at least, that was used to be called patient-centered care to home-centered care. But there's still problems associated with this type of healthcare. And so we have to adapt our guidelines and clinical thought processes and clinical judgments accordingly. 90% of the insurance payers say that advancements in telehealth or remote healthcare technologies have encouraged their organizations to move more towards home care. So that means, again, we're moving forward. Everybody is buying in. 99% of health insurances say that telehealth and remote monitoring have made it easier to provide individuals with continuous care at home. So now we're not just talking about providing health assessment and evaluation and even treatment at home, but also we are now starting to be able to monitor patients at home, which opens up a new way of dealing with patients, and that demands new clinical guidelines to be developed, because now it is possible for you to, for example, with some of the patients in my organization, they have a digital monitor to monitor their blood sugars. And every time the monitor takes their blood sugar automatically, I get the report immediately on my iPhone. So we are able to monitor these patients better now, not just able to give them telehealth in the form of evaluation and diagnosis and treatment, but we are also able to monitor them on an ongoing basis. Again, another challenge for the telehealth, telemedicine, and clinical guidelines. But which is the problem here? About 25% of the patients are concerned about whether the technology is adequate. And this opens up the door about clinical guidelines. How safe is telehealth? How safe is clinical monitoring via telehealth? These are the issues. The guidelines have to be developed to tell us more or less what can we do, what should we do, and what we should not do in regards to digital health. And then those guidelines have to be adapted as the technology is growing. I can tell you that just in the last year, telehealth technology, telemedicine monitoring has advanced tremendously. This is the technology. So we have to grow fast. It is no longer taking years. It is taking sometimes even months. So when we look at a situation of clinical guidelines in digital health, we look at it now from a holistic goal, meaning that being a patient-centered care or home-centered care, all the components of the healthcare system have to be towards the goal of providing the best care possible. It has to make it easy for clinicians to do the right thing by applying guidelines in practice more easily, quickly, accurately, and consistently. In general, guidelines have always been developed to give us an understanding of how to address a patient, how to diagnose a patient, and how to treat a patient. But now with digital health, it's changing so fast that sometimes we have to be able to readdress the patient. I can tell you this as a critical care specialist. One of the things that I would teach my students is that critical care medicine, also called intensive care medicine, means one thing. What's the difference between intensive care medicine and regular clinical medicine? In clinical medicine, you will see the patient. You will say you have high blood pressure or your cholesterol is high. Take this medicine or follow this diet. See me in 2 months or see me in a month. That's the guideline. But in intensive care medicine, hence the name intensive, I will see the patient at 6 o'clock in the morning. His blood pressure will be high. I will institute a treatment and I will reassess him in an hour, sometimes half an hour, sometimes 15 minutes. So it's more intense, hence the name intensive care medicine. And as the doors of digital medicine open up, that's how it's going to be at home. No longer do we have to say, oh, the patient cannot come to the office. The patient cannot come to the office until next week. The patient is in the office right now because the office is on our computers through digital healthcare. So what we need to do is we have to then recreate the guidelines in a way that help us make clinical decisions so that we can still maintain clinical quality and be able to measure and track and trend those qualities so that we can reach a desired health action and outcome. That's where the clinical guidelines develop in this phase now. When clinical guidelines will sometimes take 2 to 3 years, they have to now sometimes take months, if not weeks. I remember in medical school, we used to say that Harrison's textbook of medicine was, when it was published, it was already 3 years behind, but that's what we use. Now the guidelines would change sometimes every week. And when we look at the guideline development and implementation in the setting of a digital world, we see that now we have to learn not only that we have to develop new guidelines, but we have to learn to develop them quickly. And as our colleagues were saying prior to me, that we have to do investigations, we have to do analysis, we have to do statistical analysis, which is true. But now we have to be able to learn to do that faster, and sometimes accept that we might not be as accurate at first, but even though we create new guidelines, we have to continuously monitor them and reassess them and change them as necessary. Because now we create because with digital medicine, we now reach more people. With digital medicine, and these guidelines have to address not hundreds, but thousands of hospitals, thousands of healthcare people. And this has to be done much faster, but we cannot sacrifice quality. And again, we have to make sure that when we look at clinical guidelines in the digital world now, we have to make sure everybody's involved, because now everybody is part of it. Now, for example, right now, we have healthcare providers and scientists in this Zoom presentation from all over the world. So now it's not just our local neighborhood, it is everybody. So we have to just involve the guideline authors. The IT specialists now become part of the guideline process. The communicators, clinicians, the patients, medical societies, public health, evaluations, analysis. Actuarians have to now be part of the guidelines more so than before. In addition to the standards experts, the clinical decision support developers, the clinical quality measurement developers, and then ultimately the policy and technical support implementation. So with the development of digital medicine, now the team that involves the developing and implementation and ongoing assessment of clinical guidelines has become even larger. And we have to adapt these clinical guidelines for the digital age without sacrificing the outcome. The outcome is we want a good outcome. And we have to address that. In the past, the long process of developing guidelines that sometimes will average 17 years for scientific evidence to apply to clinical care. Sometimes research will not find its way to some guidelines, and it will take up to 17 years for clinical research to find its way into clinical guidelines. And we have to understand that also because of the digital reach, we have to be able to translate these guidelines to not just languages, but cultures, and also accessibility of certain treatments and medicines, because these guidelines have to be flexible enough for people that might not be able to reach or receive certain treatments. And then simultaneously create the the back office, as we call development. We constantly have to be fine-tuning the guidelines, researching the guidelines, adapting the guidelines, changing the guidelines, and maybe throwing away some guidelines and starting fresh. So this is a whole new process. And again, when we look into the development, there are various ways of developing guidelines. And this is just an example. There are processes, the narrative, the semi-structured, the structured guideline, and finally that guideline which will be executed and applied. And again, redesigning and developing an implementation is in itself a whole process. So it's not just the developing a guideline based on clinical and medical research and scientific research. It's also the process of getting it applied, which is a whole process in of itself. And that has to be adapted to the digital world. And clinical guidelines of the futures are going to be very important because the future is now. Coronavirus has made it now, not in 3 to 5 years. So we have to involve everything. And as we all know, as healthcare providers and scientists, that it is difficult enough to get 2 doctors to agree to something or 2 scientists to agree to something. But now the team is larger. And a lot of people in that team, because of digital medicine, are now sometimes not even healthcare people. They're computer experts. They're software experts. They are hospital executives and business experts. So now the world of clinical guidelines in the digital age has become larger. And why is this important? Why am I happy that our society has decided to talk about this? Because it's already happening. And it's not only happening from a medical and scientific perspective or society perspective, from a business perspective. And as we all know, when people see that this is the future and they're going to make money off of it, they definitely start making money off of it. Right now, there are companies like City Block Health here in the United States that is providing healthcare to lower economic communities. And this company has just been valued at $1 billion here in this country. And it is going to become even bigger. And this is just one company that is now dedicating itself to providing telehealth to people in our communities here in the United States. And in addition, we have to understand that the movement into home setting was happening already regardless of the coronavirus pandemic. It's just that at this point, we have to address it now. And learning and developing these guidelines are a big challenge. And I believe that we as a society of education, medical education, should be part, if not leading the way, because this is not just happening in the United States. This is happening and going to happen around the world. Thank you very much, everybody.
Thank you so much, Dr. Hector, about this interesting information.